Everybody is coming in. Thank you so much for joining us. I have some friends here with me as we're at the summit at Sunland Springs. I'm Lori Marsh, the marketing director here. We're so happy to be bringing this program to you on mild cognitive impairment. Impairment is not mild. We'd love to be able to have any of your questions. You can put them into the chat box. We are joined today with Eric Collett. He is the founder and principal at A Mind for All Seasons. It is our medical partner that helps us through our cognitive program, Enhanced Protocol. He is an invaluable resource and a wealth of knowledge, and I look forward to having a fantastic presentation on MCI, mild cognitive impairment is not mild. With that, I'm going to turn it over to Eric. Please let us know if you have any challenges or questions and by putting them in the chat box. Thank you.
Thank you, Lori. Hopefully everyone can hear me just fine. And I'm hoping that our light stays good. I am actually sitting in a hotel room in Branson, Missouri right now. I spoke to the Missouri Healthcare Association today, and so I don't have my usual luxury of the lights and setup that I'm accustomed to using. But I think we're doing okay, so we're going to move forward. I love this topic that mild cognitive impairment is not mild, because it really challenges what we know about cognitive decline. And I think it causes us to rethink the way that we approach aging in general. So some of you that have followed us on some of our webinars may be familiar with some of these statistics, but in case anyone's new, I want to just bring up a few things to kind of set the stage a little bit. It's significant that 1 in 9 adults age 45 and older reports having some symptoms, really, of cognitive decline. And you're going to meet some people through their case studies that are actually really quite young. It's scary how young some of these things can start. But there was a study done several years ago at one of the universities back east that identified that cognitive decline often starts for people in their 30s. And that's not cognitive decline necessarily that leads to dementia, but that's just things slowing down and starting to have some changes in memory. And not all of those changes that show up have to be that way. They're not all inevitable. There's a lot that we've learned about how to optimize our brain health. I think it's significant that 1 in 3 seniors dies with Alzheimer's or another type of dementia. That's not very good odds for people. And it very disproportionately affects women. 2 out of 3 Alzheimer's patients are women. Part of that is because of the hormonal picture. More than 6 million Americans are living with Alzheimer's, and that number is projected to rise significantly by 2050. We have to do something about that. And yet, if you consider the typical experience of the aging adult, people just sort of anticipate that there's going to be decline. It's like we expect that we're going to somehow cross this threshold. We don't know exactly when it is, but we're going to cross this line after which the answer when we go to the doctor's office and say, well, I'm just not feeling good with this, and this isn't working right, is going to be something like, well, you are getting older. I'm not sure what else to tell you. I think collectively, we've just sort of got to the point where we expect that significant decline is going to be part of aging. Just because something is common doesn't mean that it's normal. There are many people who live till very late in life, even past age 100, with really sharp, crisp mental functioning, and who physically maintain a lot of functioning. But that's not the trajectory that most of us are on right now, because our healthcare system is really good at treating infectious disease and was built around a program of infectious disease, but it's not very good at treating chronic disease. So on this slide, we've got a picture of a boat. And the reason why is that quite some time ago now, I talked to a client who came in with his wife. And this is a man that has pretty significant dementia. And his wife was supporting him as his care partner and had taken him to the doctor not too long before, who referred them to a neurologist. The neurologist did a pretty thorough workup. And I said, what was your experience like going to the neurologist? And this lady said, it was terrible. It was the most devastating thing that we've ever been through, because the neurologist basically did a lot of testing and then came back and said, well, you have Alzheimer's disease. There's not much I can do. I'm so sorry. And that was it. And she said, it was exactly like that doctor put us in a boat, took the oars away, shoved us out on a rough sea and said, see you later. Good luck. But come back in 6 months and we'll see if you've gotten any worse. That is a terrible feeling, and we can do so much better. When a cognitive score is going down, when someone is aging, it means something. It means that progressively, tasks that used to be simple are now hard, and tasks that used to be possible have become impossible. And as that progresses to the point that people have a more definitive diagnosis, like Alzheimer's disease, it represents a complete loss of independence. And typically, Alzheimer's is considered a terminal disease. Eventually, the person will lose 50 to 70% of the mass of their brain, and it's a slow, awful, ugly kind of a death. Well, that's not the kind of thing that anybody really wants to talk about. That doesn't excite people at parties. So what can we learn about the trajectory of aging from some of the current work that's going on? I want to share a little bit of that current work, and we've redacted information here, but recently you'll see that this comes from May of this year, the end of May. We were doing some cognitive testing with a 48-year-old woman, and these are the results. And these are valid test scores. This is a computer-based cognitive test that's kind of like a trip to a neuropsychologist's office, only you don't have to sit through 4 hours. It's a battery of tests that allows you to see a lot of different domains of cognitive functioning. And look at how many scores were just painfully low. Her overall neurocognition index, which is kind of a synthesis of all of these different scores, was in the 4th percentile. And even though her reaction time was considered average, average is a wide swath under the bell curve. Here she is, 48 years old, and her reaction time was in the 45th percentile. And even though her reasoning was average, it was in the 50th percentile. She was not doing very well at all. These are scary scores that really demonstrate that she's got mild cognitive impairment. Especially for someone age 48, it's surprising to see things that bad. When it comes to aging, most of us just have this sense and this belief that, well, we don't know exactly what path we're on. There are a lot of different trajectories. And some people live past their 90s, and it's kind of a slow glide slope into the finish line. Other people start to decline much faster, like this 48-year-old that is honestly headed toward a memory care unit if things don't turn around. It's a good thing that we started intervening and that we're doing something about this. So this kind of discussion leads a lot of people to wonder, well, what slide am I on? What slide is my spouse on? How about my adult children? And is there anything that we can do to change this trajectory? Well, there's a lot that can be done to change the trajectory, but we've got to start with changing our nomenclature. Words matter, and words cause us to view things in specific ways, and they cause us to exclude other viewpoints. So before we talk a little bit about what you could do about these kinds of things, let's talk about why mild cognitive impairment is definitely not mild. The way that we describe early stages of Alzheimer's disease is highly misleading, and it causes people to just not take action, and they think that it's not so bad. If you hear something like mild cognitive impairment, the word mild sounds kind of innocuous. So I want to put it in perspective a little bit. And I'm going to start by giving you an example of cancer and how we treat cancer. And I want to juxtapose that with how we deal with cognitive decline, because our approaches are really very, very different. So when it comes to cancer awareness, most people are really aware of cancer. It kills a lot of people every year. Most people know somebody in their family that has dealt with cancer. Many people are cancer survivors, and they certainly don't want to go down that road again. So when it comes to cancer, we do a lot of prevention and a lot of screening to try to identify cancer really early. And then we stage cancer. Oftentimes when someone gets a cancer diagnosis, people will say, well, what stage is it? And most people know there are 4 stages in cancer, and they have a vague idea that stage 4 is really, really bad. And stage 1, we can probably do something about it. And 2 and 3, it depends on the type of cancer and everything that's going on. So what kind of cancer prevention strategies are out there? Well, we have breast cancer screening, for example, where women are encouraged to do annual self-exams and to get a mammogram or an ultrasound. And if there is something there, well, let's biopsy that. Let's look at it early. Let's intervene as quickly as we can. When it comes to cervical cancer, well, we do pap smears and HPV screening, and we do Gardasil vaccinations. When it comes to colon cancer, we do mouth swabs. We do routine colonoscopies. We look at stool samples. When it comes to lung cancer, we do smoking cessation programs because we know your risk of cancer of the lungs goes way down if you're not smoking. So we work hard on that. We do public service announcements. We do chest x-rays. And when we do find cancer, we do something about that. There are even cancer screening guidelines that are stratified by age. This comes from cancer.org. And you can actually look up what kinds of screenings should be done between ages 21 and 29, 30 and 39, and on up. So we stratify it by age because we have recognized that throughout life, those risk factors change. And different types of cancers tend to be more risky at different stages of life. So we pay attention to that. When it comes to staging the cancer, early stage is when you find a small invasive mass or a tumor. It may be something that you didn't even find. It may be during a breast self-exam, for example, if you're a woman. Not that men can't get breast cancer. I actually have a friend that did not too long ago. But usually it's women. And there might be a small mass that women don't even feel, but they go in and have some mammography done, and something suspicious comes up. And so there's a biopsy, and we might identify, yeah, this is breast cancer. But it's small and it's localized. It hasn't metastasized and spread throughout the body. So yeah, we're going to intervene. And stage 2 is still localized, and it's started to affect nearby tissue, but it's kind of contained. And there may be a little bit of spread to lymph nodes, but it's all near the tumor mass. So it's still keeping things under control. Stage 3 and 4 just get worse and worse. And by the time it's a stage 4 cancer, the cancer has spread to other organs and tissues. It's gone way beyond where the tumor originated. You might have tumors showing up all over the body at that point. It's often called metastatic cancer. So in stage 1 cancer, where it's hardly detectable, you can't even see it in a lot of cases on a self-examination. We focus on early detection. We biopsy things. We try to figure out, is this malignant or is it benign? Is it just a mass of cells growing, or is it something more serious? We do surgery, we do chemo, we do radiation. In other words, we really get after it in the same way that we would get after later stage cancer. And when someone has a more rare form of cancer, and there's not really a great treatment, but maybe there's some new experimental things that have come out, oftentimes doctors will talk to their patient and say, there's nothing definitive here, but there is a new option, and your cancer is stage 4. You're likely to die within 6 months, but there is this thing that we could try. And most patients will say, yeah, it's worth a shot. What do I have to lose? I mean, you're telling me I'm terminal, so I'll try anything at this point. And I recognize that some people get to the point that they say, no, I think I'm done with that. I'm going to accept this. And death does come to all of us. The number one cause of death is being born, and we shouldn't ignore that fact. But there is a question of quality of life and how do we live? So for at least a long period of time with cancer, we really get after it. We try to do everything that we can. Imagine what it would be like if our response to cancer was like this. Oh, don't worry, Mrs. Smith. You only have stage 1 breast cancer. It's not a big tumor. Don't sweat it. The mass is small, hasn't traveled, hasn't metastasized outside the breast. Take some ibuprofen, stop smoking. We'll get you back in a few years. We'll recheck it. We'll see if it's bigger. We'll see if it's spread to any other part of the body. See you at your next wellness visit. Can you imagine how bad it would be if that is what we said? If that's how we actually responded? And yet we say similar things all the time about dementia. It is so common that people will start to notice some brain fog. They'll start to notice what they label senior moments or brain farts. We even joke about it. And those things really don't need to be happening. They're evidence of a problem. Now, that doesn't mean that everybody that has senior moments is going to develop what would warrant an Alzheimer's diagnosis. It doesn't mean that at all. But it's a sign that something is not working right. Something is wrong. If it's more than just being distracted and not paying attention because you got too much on your plate, and it's happening more and more frequently, that is a problem. And there's a lot that can be done very early on to identify cognitive decline. And yet people go to their doctors and they say, yeah, I'm just feeling foggy. And the doctor's like, well, you are getting a little bit older. Be careful what you eat. But there's not really a lot of advice given about how to deal with that. And, in a 10-minute doctor's visit, which is fairly standard these days, it's difficult to deal with something that is caused by many, many different factors. And so it's very easy for a doctor to default to, well, let's review the medications that you're on. And maybe there's a little change with something here or there, but we tend to just focus on symptoms and let's treat symptoms and we'll see you back in 6 months and we'll monitor and you're fine at this point. And that is really galling to me. The more I learn about this, the more it is very frustrating that we treat cognitive decline in that manner. So here's how dementia staging works right now. Stage 1 is kind of preclinical development where nobody's even tracking that at the doctor's office. The brain is changing, but you're not seeing outward manifestations of that. Most people have Alzheimer's disease for 10 to 20 years before symptoms even show up. That's pretty devastating to know. And it would be really frustrating if there was nothing we could do about it. Thankfully, there's a lot we can do about it. And a lot of the top neurologists in the world that study Alzheimer's disease have come out recently and said, Alzheimer's should be rare. You can do something to prevent it. In fact, it's not something, it's some things. There are many different factors that lead to those kinds of problems. And by using a multi-pronged approach, we can deal with it. Stage 2, though, is subjective cognitive impairment. This is where someone recognizes that they're slipping. They realize, hey, I'm not as crisp as I used to be. Things aren't quite right here. Things are deteriorating. This is a stage where, frustratingly, many primary care providers just kind of brush it aside because there's nothing that they can really measure with a pencil and paper test yet. And yet there was some recent research that looked at how often people who had subjective cognitive impairment actually down the road ended up developing dementia symptoms. And they found that 80% of the time, people who have subjective cognitive impairment are right about it. They do go on to develop further problems. So it's no laughing matter when someone has this unsettling sense that, hey, I'm slipping. Things are not good here. Stage 3 is mild cognitive impairment. Notice where we put that. If we were to compare this to cancer, stage 3 cancer is like, oh my goodness, this is a huge problem. This is spreading. By the time something is labeled mild cognitive impairment, there have actually been years, sometimes 2 decades worth of decline to get to the point that it's now measurable. When it's mild cognitive impairment, that means it's not severe enough to be classed as dementia, but we can measure that decline. It shows up on cognitive tests. We still have preserved activities of daily living at that point. People can dress themselves, they can bathe themselves, they can usually drive, they can handle a lot of things, but they're definitely having symptoms that are impacting their work. Many people have to quit their jobs when they have mild cognitive impairment. They just can't keep up. Stage 4 is when someone has a dementia diagnosis, and Alzheimer's disease is the most common cause of dementia. So sometimes doctors will do enough testing that they actually step out and say, yeah, this is likely Alzheimer's disease. Other times we just slap the dementia label on it because that's also an accurate term. It refers to symptoms of cognitive decline that are disrupting daily life. So now clinical tests have identified the problem. Now activities of daily living are impacted, and they're likely to continue being impacted down the road. And the caregiver burden and expense increase exponentially. The average lifetime cost for taking care of someone with Alzheimer's disease is right around $340,000 right now. And that was before all the inflation that we're going through at the present time. So it's probably even more than that, maybe over 350, 355, 360. It's crazy scary to think of how much money we spend on this disease. And it makes sense why so many people have said when the silver tsunami hits and the baby boomers start having cognitive decline at a massive level, it's going to bankrupt the healthcare system. We have to do something about this. So think about cancer compared to dementia. Stage 1 cancer, it's early detection, it's surgery, it's chemo, it's radiation. And with dementia, we brush it aside until someone is in stage 4. It's kind of like we notice that someone's house is on fire and we say, oh, it's just a stovetop fire. We'll keep an eye on that. We'll watch that. And we wait until the house is completely engulfed in flames to say, oh yeah, you're right. You got a big problem here. That's a huge issue. Guess you can't stay in that house anymore. So frustrating that that's how we treat it. And all that we do is give pharmaceutical agents that are predicted at best to slow the decline a little bit. We make sure that the house burns to the ground at a little bit slower rate. What if we could actually put some water on that? I want you to hear a little bit of a segment here from an interview on a podcast by Dr. Nate Bergman. He works at the Cleveland Clinic. And he, in this podcast, is interviewing Dr. Dale Bredesen from UCLA, who has been a pioneer in the research for Alzheimer's prevention and Alzheimer's intervention. So here's a little bit of Dr. Bredesen talking about Alzheimer's nomenclature.
Success. So here in our trial, we have, these beautiful results showing that actually a large majority of our patients improved. 84% improved, 12% stayed the same, and 4% declined.
And if I could just add one thing here, Nate, there are a couple of critical pieces, and you alluded
Hey, Eric?
to comparison
Yes.
with other things.
Can you pause that for a second?
Yeah.
I don't think that you're running the audio through like we normally do.
Yeah, I actually clicked that button that I'm sharing audio. Let me try it again and just see if we can make that work. And yeah, we've got share sound going on here. So I'll try it one more time.
Okay.
Sure. We need to change the way.
Can you hear that at all?
Cognitive decline, because
We'll do our best.
Mild cognitive impairment before dementia. And if you think, really that it should be called relatively late stage Alzheimer's disease. When you have mild cognitive impairment, you've already had, on average, 10 years of subjective cognitive impairment. That's been well documented. And before that, you've had some period where PET scan.
Okay, sorry.
Would be abnormal, spinal fluid would be abnormal, but you are still asymptomatic. So really, asymptomatic is essentially pre-Alzheimer's. SCI is really early Alzheimer's, MCI is relatively late stage Alzheimer's. And by the time you're actually called full-on Alzheimer's, where you're actually beginning to lose activities of daily living by definition, this is like saying someone has widely metastatic cancer. This is an end-stage condition. So as Kat indicated, the people that were in the trial either had MCI, so they'd had more than 10 years of pathophysiology, or they had, quote, early dementia, which is really very late-stage changes. And thankfully, these people, for the vast majority, as Kat indicated, actually showed improvements in their MoCA scores and improvements in their CNS vital signs neurocognitive index, which is an excellent online way. And even, interestingly, the MRIs even showed improvements. So,
okay. So what?
Eric,
Yes.
Eric, you need to recap what he said. It was very hard to hear. It was very hard to hear. So if you could just recap it for us.
Okay. So Dr. Bredesen was talking to Dr. Bergman about a recent study that they just published the results of. And Dr. Bredesen has been publishing papers on Alzheimer's disease for the last 30 years. But since 2014, he's been publishing papers about a multimodal approach, which ultimately he named RECODE, for reversing cognitive decline. And they recently did a study with 3 different study locations, 3 different investigators or doctors leading these trials. And in that study that was institutional review board approved and structured as a really thorough study, they found that 84% of the patients showed significant improvement. On average, their cognitive scores on a 30-point test went up 5 points. And to put that in context, it's expected that someone with Alzheimer's disease will decline about 3 points every 9 to 12 months. They used a drug as well with one of the study groups, and that group declined only 2 points on average over 9 months of the study. So the drug was identified as, well, maybe it's helpful because they don't decline as fast. But the people that were actually doing this protocol that involves addressing nutrient deficiencies and hormonal deficiencies and calming inflammation and improving exercise and changing diet and using stress management techniques and looking at toxic exposures and doing things to mitigate those exposures. People that went all in with a multimodal approach like that improved significantly. And he was saying even their MRIs showed improvement. So the volume of structures of the brain was actually better for those people. And he talked about the fact that many of the participants had either an Alzheimer's diagnosis or an MCI diagnosis, mild cognitive impairment, which he again talked about as being indicative that they've had problems for 10 or 15 years by the time they have that MCI diagnosis. So it was just a little bit more insight and take from Dr. Bredesen, one of the pioneers in the field, on this idea that really we wait till Alzheimer's is synonymous with metastatic cancer. And this slide that you're looking at tells us a little bit more of how Dr. Bredesen recommends that we really should be talking about this. And Randy and I and our team agree with this. So there's a preclinical stage, but what is now named subjective cognitive impairment should be called very early Alzheimer's. Mild cognitive impairment should be called more of moderate to late stage Alzheimer's. And by the time someone has Alzheimer's disease, it should be called end stage Alzheimer's. It's not unlike metabolic problems. Alzheimer's is actually nicknamed diabetes of the brain in the medical world. And when it comes to type 2 diabetes, which has gone up 30% in the last few decades, we treat type 2 diabetes a lot the same way. Type 2 diabetes is not really a problem of excess blood sugar. It's a problem of excess insulin. So people become a type 2 diabetic when they eat a lot of sugar, standard American diet, And their body has to produce a lot of insulin to deal with all that sugar and get it into the cells so that our little energy factories in the cells can make energy with that. And when you have high levels of insulin, it's kind of like someone screaming. When someone screams, we cover our ears because it's painful. And when insulin is screaming, insulin receptors are downregulated. They become less sensitive because that insulin signaling is so strong that they don't need to be so sensitive. When people continue eating that high level of sugar, that standard American diet, processed food diet, day in, day out, insulin levels stay so high that the pancreas has to keep doing more and more and more work. And those insulin levels have to keep rising over time to get the job done. Now, insulin is our hormone of growth and storage. So when you eat a diet like that, you start gaining weight. So this is what's driving the obesity epidemic. And as you start gaining weight more and more, it causes cardiovascular problems as well. And elevated blood sugars can damage tissues, and that chronically elevated insulin level starts to wreak havoc throughout the entire body. Unfortunately, when you go to the doctor's office, we test blood sugar, but we don't test fasting insulin on a routine basis. Your insulin level might be sky high, but if it's still getting a response from your insulin receptors, your body is still able to get that sugar into the cells. And yeah, you gain more weight, but your blood sugar is quote unquote normal. Unfortunately, if that process continues over about a 10-year time span, your pancreas finally will burn out and say, enough already. I just can't keep up with this. I can't do this any longer. And that's when insulin production just crashes and your blood sugars go up. And all of a sudden, the doctor says, oh, wow, you've got elevated sugars. You're pre-diabetic or you're a diabetic. In other words, we wait until end-stage metabolic problems show up before people even get a diagnosis. And that's exactly what we're doing with diabetes type 3, diabetes of the brain, Alzheimer's disease. So think again of the 48-year-old that had all these really low cognitive scores. What can be done? Well, when we look at her health history, we find that she's having some brain fog. She came to see us because she wants to prevent Alzheimer's disease, and she's worried about it because she's seen so many people deal with this. She's got subjective cognitive impairment by standard measures, but when you do more sensitive testing like we did and like that CNS vital signs report that I showed you, then you realize, oh, this is a mild cognitive impairment diagnosis. She's got short-term memory loss. She's got problems planning and organizing. She's lost her social filter. And she's got a family history of dementia. This doesn't look very good. She also has a history of head trauma with loss of consciousness and a concussion. It happened from a motor vehicle accident. She's had a history of physical abuse. Clearly, a tough life that she's been through. She awakens unrested and she snores. So she's a poor sleeper and she's not had oximetry testing to find out if she has obstructive or central sleep apnea. She's had some root canals, and the same bacteria that causes gum disease can get into the brain. That can be a dementigen, something that helps to cause dementia. She's gone through menopause already, and she was very symptomatic. And she has frequent urinary tract infections. So she's got early hormone insufficiency. And one of the reasons that 2 out of 3 Alzheimer's patients are women is because they have so many more hormonal problems and fluctuations. Head trauma also causes major upset of hormones because often head trauma damages the very sensitive pituitary gland. And so you see issues with growth hormone and thyroid stimulating hormone and pregnenolone, which is a master hormone for the brain. and a number of other things that are impacted when the pituitary gland gets damaged. She's had potential mold exposure from a home flood. She has chronic persistent allergies that are often a symptom of toxic exposure. She takes allergy medicine all the time. She grew up in an area where there was a lot of crop dusting. That also represents exposure to different dementigens. So all of these things come up in a much more comprehensive kind of workup than you ever get it in a standard doctor's checkup. When you check a lot of lab work, you also find other interesting things. On a Montreal cognitive impairment, or excuse me, on a Montreal cognitive assessment, she shows impairment. She scores 25 out of 30. Normal score is considered 26 out of 30, but really a healthy adult should be getting 30 out of 30 pretty consistently. So she scores 25. And a lot of people would pass that off as, well, you know, maybe you had a bad day. Maybe you didn't sleep all that well. But there's a lot of other stuff that shows up for her. She doesn't carry the so-called Alzheimer's gene, but she does have 2 copies of a genetic SNP that primes her body to struggle using B vitamins efficiently. And when that happens, it goofs up your body's detox pathway. It goofs up your body's ability to make neurotransmitters, and so you develop mental health problems, which she has, and a host of other issues come up. We looked at her glutathione, which is the body's master antioxidant. And her glutathione was very depleted from where it should be. It was 287. It should be much, much higher than that. So she's got all these things that line up. Now, I won't go into every lab that we did, but the point is there is so much stuff that you can look at and identify what is going wrong. These are like holes in a leaky roof. And it makes a difference when you try to patch all the holes versus just trying to patch one hole or not even being aware of those holes. So really, we're talking about iceberg medicine here. Are we just looking at what's on the surface? Are we treating symptoms? Or are we going to use a more functional medicine approach, which gets to the root causes? Are we going to look at what's going on with a person's hormonal levels? What's going on with their nutrients? What's going on with chronic inflammation? How about exposure to all these different dementigens? It's going to look different from person to person. But if we're really thoughtful and very thorough in looking at these things, the research that has come out in about the last decade has been most impressive. And we have now done this kind of approach with many hundreds of people in the last few years. And we have seen impressive turnarounds for individuals. Dr. Bredesen has confidently said, and this is definitely our experience at A Mind for All Seasons with our partners like the Summit at Sunland Springs, that if you can intervene early when it's subjective cognitive impairment, virtually 100% of the time, you can turn that around. By the time it is mild cognitive impairment, almost always, you can turn that around. You can help someone increase their scores till they have normal scores. And when someone has deteriorated to the point that they warrant a dementia diagnosis or an Alzheimer's diagnosis, you can make a big impact. The jury's out how big of an impact you can make. It's very individualized, but even in that most recent study from Dr. Bredesen and his team, they saw several people improve from a score of 19 out of 30 to 30 out of 30. And we've certainly had those experiences time and time again. So hopefully this gives you an idea that our approach is very different. We are not content to just treat things at the surface level. We're not content to look at symptoms and to wait for people to have massive problems. We treat the body as a system. And we recognize that if you're going to deal with a system, you have to look at all the parts of the system and really intervene. You can't help a boat that is sinking because it's got 30 holes in the boat if you just stick a finger in one of those holes. You've got to plug all the holes in the boat. And that's what we do. This is a very busy slide, but this is an idea of what we do with the enhanced protocol and why people can have hope for better brain health. When someone says, oh, there's nothing you can do about dementia, I call baloney on that. There's now a ton of things that you can do. And there might not be a guarantee, but why would we treat it differently than cancer? If someone is struggling with cancer that's likely to claim their life, we often throw everything but the kitchen sink at it. Why would we not do the same thing when it comes to cognitive problems? And why would we not intervene early and use early screening and early intervention for everybody? Well, you probably have some questions or some comments or some thoughts that you'd like to chime in with. So let's have a little bit of discussion. I think Robeson's probably with us. I'll let Lori lead out on that, but Lori, maybe you can let us know if people there have questions, or I know we've got a bunch of people watching online, and if you have a question online, you can put it in the Q&A or put it in the chat, and we'll be glad to talk with you more about this.
Thank you so much, Eric. I appreciate that. I have had a number of presentations with Eric and the team from A Mind for All Seasons, and I learn something new every single time that I get in the room with them. Eric, maybe you can look at the chat for me.
You bet.
I think if I try to look at it, I might screw up the whole screen thing. So if you have questions, pop them in the chat, but what do you think?
So and if you're online, put it in the chat rather than the Q&A, just so you don't get confused. It's very difficult to have both open at the same time. So let's just use the chat window.
Thank you.
Enlightening.
Enlightening?
It's enlightening.
Oh, it is enlightening.
Yes,
Yeah.
that was wonderful.
Good. It's Pat, right?
Mhm.
Pat was mentioning when she came in how she has switched her diet to a plant-based diet. There's a history of Alzheimer's, dementia in her family, and she's doing everything possible to, not be another statistic. And she has felt fantastic since changing the diet alone. So you can see.
I get a lot of, it's weird. You get a lot of flack from your friends that say, oh, why? But I've kind of got them all, back away, let me go, I'm doing fine. And I tell you, I feel a lot better these days. A lot.
Great.
Yeah. And sometimes people watching wonder, well, what do I have to do dietarily? Like, what is the diet for this? Diet is very controversial, and the whole world fights over diet and can't agree on what the right diet is for the human body. So here's our philosophy overall. Number one, we get further with principles than with something that's really rigid. So principles of a good diet are this: processed foods don't belong in the human body. They're not real food. So that's a principle that people on all sorts of different sides of the diet continuum can agree on. Another thing that people agree on is that we eat way too much sugar in the westernized world. And that sugar shows up in a lot of forms. It can be a plate of pasta. It can be a candy bar. It can be a soda. It can be a slice of bread. Carbohydrates break down to sugars. So we have to be conscious of that. The other principle that I would say is that how we eat needs to be influenced by the fact that food is fuel. And the way that we're running the engine dictates what kind of fuel we need to put into it. And there are also some genetic tendencies to keep in mind. So my son, my oldest son is a senior in high school. He's a cross-country and track runner. And most days as he's training for the cross-country season, he'll run anywhere from 8 to 10 miles. And he comes home and he eats a whole bunch of carbohydrate. And he should, because he needs to replace his glycogen stores in his muscle. And that's the first place that sugar gets stored when we eat it. So that makes a difference. But if you're 85 years old and you've been sedentary for the last 50 years and you're 300 pounds overweight, the last thing you need is to eat a bunch of carbohydrates. Your body needs to shift into fat burning mode, which only happens if your insulin level stays down. And that happens through fasting and through eating a diet rich in fats, which don't prompt an insulin response. Some people benefit from eating a mostly plant-based diet. Other people have methylation problems where it's really hard for their body to use B vitamins. And if they don't eat a little bit of meat, they don't do very well. They feel terrible. So diet needs to be customized based on a person's goals. But in general, if it's whole, real food, it's good food. The question then just becomes, what are your goals? And what's going to get you closer to the goal? So I don't want anyone to be afraid of having to stick to some particular rigid diet. We need to figure out what works for your body and what will make the biggest difference for you.
That's great. We'll see if there's any questions that come in the chat, but from a personal experience, I've done the testing, and to see that I have a genetic marker for Alzheimer's, that's a little bit of a surprise. I don't have any history in my family, but as we really look at is just because there might be the genetic predisposition for it does not mean that that is the case. There's so many things that I can do right now to be able to provide my body the nutrients and really keep an eye on my hormones, really keep an eye on my sugars and what I'm putting in my body, so that I can look forward to the latter years and not be the burden onto my husband or to my family to say, if this is forming 10, 20 years before you really see symptoms, now I have the tools. That's what's been so eye-opening.
Yeah, I want to speak to that genetic comment just a little bit, if I may, Lori. People often get afraid of doing some genetic testing. And I like to remind people that genetics might load the gun, but it's your choices that pull the trigger. We recently worked with one of our other partners. There's an assisted living community in another state that does this lab work on every resident that they have. And so we see interesting trends with those big groups of residents. And we recently looked at a group of 26 residents in one of their buildings. And out of those 26 residents who were all diagnosed with some level of cognitive impairment, only 6 of them had a copy of the APOE4 allele, which is considered the Alzheimer's gene. And nobody had 2 copies of that. Virtually everybody, except for those 6, was APOE3/3, very, very common genetic type. And yet they all had cognitive problems. So just because you don't have the quote unquote Alzheimer's gene doesn't mean you're home free. There are still lots of ways that the brain can deteriorate. When you know, though, that you do have that gene, what it tells you is that you're more likely to have a problem with chronic inflammation. Your body and your brain are primed for a stronger inflammatory response than the average person. And it also tells you that you're much more likely to have some issues with insulin resistance in the brain. By the time people with the Alzheimer's gene get into their mid-30s, PET scans tend to show a 10% drop in the ability to use sugar. If you know that, and you manage those factors and you do things to keep your level of inflammation really low, and you kind of check inflammatory markers at a regular interval. And if you understand that you're more likely to be insulin resistant, and so you eat a diet that really manages your sugars effectively, and you know the right things to check over time, you don't have to live in fear. And just because you're an APOE3/3 doesn't mean you're home free. You're actually more likely to have issues with toxicity-related cognitive problems. So it doesn't matter how you slice it. Any genetic type has a strength side and a weakness side to it. And our job is to understand both of those sides and to leverage the strength side and to manage the weak side. If you have APOE4 genetics and you're primed for an inflammatory response, and you're 15 and you step on a rusty nail and your immune system fires up and saves your life, that's a really good thing. But having chronic inflammation for decades is a problem. That's what I mean by strength side, weak side, and how do you manage that?
Thank you. I know Eric put on the screen information for Robeson Flynn, the memory coach here at the summit. He's not with me here today, but if you would like some more information about the memory clinic that we have at the summit, it's an outpatient program where people come through do brain therapies, work with our coaching staff on what they can do for their individual personalized case, get a personalized roadmap along with being able to get some of the lab work done and see where some of those nutrient deficiencies or some hormone issues might exist. We'd love to be able to help you. You can reach out to Robeson on the email there, or me, Lori Marsh. You would have received an invite from me, or have my email address in some sort of form of communication that we've already had to bring you here to this. Some way we connected. But I don't see any further questions up in the chat box, unless you do, Eric.
No.
And so,
Nope, I don't. It's good to have everybody here with us. Thanks for watching today.
thank you so much.